అయిపోయింది ఏం చేయమంటారు
Shall I
రోజు
start?
చూస్తాను
Hello?
yes
Hello.
yes ma'am yes ma'am
Yeah, I think you're not muted, so I'm hearing your conversation this side.
okay just
Hello, dear students. Welcome to Auricle Intensive Revision Series. So we are doing the revision of lower limb. So here we are doing rapid revision of all the important questions, quick revision of volatile facts, and we're also covering all the high-yielding topics and expected questions. So this is beneficial for all the university exams of all the states. So we'll be dealing with some long essays, short essays, and short answers of lower limb today. And before we go in, let us understand why we choose Auricle. So Auricle offers a plethora of services. So here we have recorded classes where it allows you the flexibility of learning. So you can access the classes anywhere and anytime, and you can do multiple revisions. Also, so you can go over and over again to understand anything. And the expert instruction is from top faculty with in-depth knowledge of the syllabus, and they ensure that you understand every topic clearly. And these recorded series are also helpful for your revision, so you can revise the subjects at your own pace, eliminating the pressure of catching up. There is also live classes. So live classes, here we cover in depth all these subjects. We also do past 10 years question papers. So these are all from experienced educators, and live classes offer you an interactive sessions where you can participate in the live doubt clearance as well as MCQ polls as well as Viva OC and many more. We also have express exam module. So this module, it completes the syllabus, the entire syllabus in 20 hours. It is a comprehensive and efficient coverage, especially just before the exams. Here we also teach you the answer writing skills, so you can master the art of high scoring responses, whether it is in way of diagrams or flowcharts or effective answer writing skills. So these are all from expert educators who are more than 10 years of experience. There is also one-to-one doubt clearing session here. So it offers you a student-centric approach, and you get personalized attention, and it offers also a safe learning environment. So you can ask and resolve your queries without fear of being judged in a supportive and understanding setting. And when you subscribe, you also get additional hard copy note sets. So these notes cover the entire syllabus in a very effective manner. So they are in every chapter, every topic is in a question and answer pattern. And it is very crisp and clear, where you can do a rapid revision of it. It helps you in easy understanding and recalling. There is also question bank to hone your skills of answering in the exams. So this is from beginner to expert level. Okay, so it's customizable question bank for better exam readiness. There is also practical sessions also, so where you get a hands-on experience engaging in interactive sessions that simulate the real clinical scenarios. We also give you expert guidance from seasoned professionals with extensive practical experience. You can excel in practical examinations. You can revise the practical classes before your examinations and ace your practicals and Vivas. So there are 3 subscription plans. So basic, standard, and premium. So the service in premium, we offer you the services which include in basic and standard. In addition to that, we also give you one-to-one personalized guidance and notes are given. So you can use the code Dr. Divya 20 for discount on subscription. So we'll start with today's class. So it's the 5th revision of fifth class of lower limb revision. So the first long essay question is describe hip joint under the following headings. So usually any joint, when they are asked to describe, either it may be asked under the subheadings or it may be asked like, just to describe the joint. So whenever a joint is asked to be described, it should be like answered under what is the type of joint, what type of joint it is, what are the articulating surfaces, okay? Then the ligaments and the capsule of the joint, the relations of the joint, the movements and the muscles producing the joint, and mainly the applied anatomy. These should not be missed at all, okay? These should be written. So here, this is a very repeatedly answered question, as you can see in the number of times it has been asked there. So first is the type of joint. What is the type of joint? It is a ball and socket type of synovial joint. So articular surfaces are the head of the femur, okay, it articulates with the O-shaped acetabulum of the hip bone, okay, to form the joint. So the ligaments of this hip joint are the capsular ligament, the iliofemoral ligament, pubofemoral, ischiofemoral, transverse acetabular ligament, acetabular labrum, ligamentum sternus femoris, or the otherwise called as the round ligament of the head of the femur. Okay, so those are the ligaments of the hip joint. So you just need to that the important of these are the capsular ligament, the iliofemoral ligament, okay, which provides the strongest support to the joint, and pubofemoral and ischiofemoral. Okay, so those are the main ligaments there providing the support to the joint. So when you talk about relations, you can draw a diagram like this, and you can see here it is as how it is labeled here, anterior relations, and all the anterior, they are listed out here. Okay, posterior relations, inferior relations, superior relations. Okay. So just like that, you can so here, as you can see, the anterior relations here include the straight head. So this is the joint, okay? So this is the hip joint. So we have taken a transverse section here. So when we can see here, there is the straight head of the rectus femoris, the tendon of iliopsoas muscle. This is the synovial bursa, femoral nerve, femoral artery, then the femoral vein, okay, and the pectineus muscle. So these from about downwards as we come here, all in an order. Straight head, tendon of straight head of rectus femoris, tendon of iliopsoas, synovial membrane, femoral nerve, femoral artery, femoral vein, okay, and pectineus. They form the anterior relations. Superior relations include gluteus maximus, gluteus medius, okay. So here you have gluteus maximus, medius, minimus, and the reflected head of rectus femoris. So they form the superior relations. Whereas the posterior relations include here the piriformis. So these all will be under the cover of the gluteus maximus. So piriformis muscle, the sciatic nerve, obturator internus and the two gemini, the quadratus femoris with the nerve to the quadratus femoris, and gluteus maximus also forms part of it. Okay. And inferior relations include obturator internus muscle and the medial circumflex femoral artery. That will be the branch of the femoral artery, medial circumflex femoral artery, okay, coming from the profunda femoris artery. So movements and muscles producing the movements. So what are the movements? So movements which takes place mainly at the joint include flexion, extension, abduction, adduction, medial rotation, and lateral rotation. So you can make a table of this and write, okay? So you don't have to write like a sentence writing. So this will save you time and it will give a good presentation. So flexion is mainly by the psoas major and iliacus. Other muscles, okay, which support the movement are sartorius, rectus femoris, and pectineus. Extension is mainly gluteus maximus and hamstrings help. Abduction, gluteus medius and minimus, they are the main muscles. Tensor fasciae lata and sartorius are accessory muscles. Adduction, adductor, all the adductors, adductor longus, brevis, and adductor magnus. They are the chief adductors. Pectineus and gracilis are accessory muscles. Medial rotation is basically the anterior fibers of the gluteus maximus and medius. Sorry, gluteus minimus and medius, which are the medial rotators. And accessory muscle is tensor fasciae lata. Lateral rotation is by piriformis, obturator externus, obturator internus, and the associated gemelli muscles, quadratus femoris muscle. Okay. So these muscles, they are known as the short rotators. So hip joint is mainly supplied by the medial circumflex femoral artery, lateral circumflex femoral, obturator, superior gluteal, and inferior gluteal artery. And it's supplied by the femoral nerve through nerve to rectus femoris, a branch from the anterior division of obturator nerve, branch from accessory obturator nerve if it is present, branch from nerve to quadratus femoris, from the superior gluteal nerve, and also from the sciatic nerve. So all these nerves supply the hip joint. Clinical correlation. First is dislocation of the hip joint. Okay, so dislocation can be congenital or acquired. So Perthes disease, or it is also called as pseudocoxalgia. So it is a clinical condition where there is destruction and flattening of the head of the femur. Okay, so because of that, there is an increased joint space when we see in a radiograph. Coxa vara and coxa valga. Okay, so normally the neck shaft angle is about 120 degree in adults and about 160 degree in children. So if the neck shaft angle of the femur is reduced, okay, like in fracture neck of femur or Perthes disease, it is called as coxa vara. So so when the neck shaft angle is reduced, it is coxa vara. Okay, so it can be because of the fracture neck or Perthes disease. But if the angle is increased, okay, like in congenital dislocation of the hip joint, it is called as coxa valga. Valga is increased angulation and decreased angulation is coxa vara. Okay. Then osteoarthritis. Osteoarthritis is basically a disease of the old age. So basically the osteoporosis, osteopetrosis, and then further osteoarthritis happens. So here what happens, there is growth of osteophytes at the articular ends, which not only limits, because of that, there is limitation to the movements of the joint. Okay, so making it very grating that osteophytes, no, they are the, like, bony projections. Okay, small bony projections, and that will make them grating and painful. Then referred pain of the hip joint, like in diseases like tuberculosis of the joint, the pain is referred to the knee joint because of the common nerve supply. Then that is aspiration of the hip joint. Okay, so not knee joint. So aspiration of the hip joint is usually done by putting a needle 5 centimeters below the anterior superior iliac spine, upward, backwards, and medially. Fracture neck of the femur is common, so where it is referred as fracture hip because that fracture neck of the, because the femur, it forms the part of the hip joint, femur, head of the femur, and neck is closely related to the head. So it is also called as fractured hip when the neck of the femur is fractured. Okay, so these fractures are more common in individuals of more than 60 years of age, especially in females, because the femoral nerve becomes weak after menopause. It becomes weak and brittle because of osteoporosis. Next important question is name and describe the arches of foot. Okay, and here they have specifically mentioned lateral longitudinal and medial longitudinal under the following headings. Okay, so they are also given the headings: types and bones taking part, factors maintaining, applied anatomy. So as you can see, it's a very, very important question, arches of foot. Okay, so so what do we mean the arches of foot? Basically, the skeleton of the foot is arched. Okay, so to allow for the smooth movements when we walk on a rough surface. So that is the arches of foot. Now these arches of foot are further classified into longitudinal and transverse. So longitudinal are medial and lateral. Transverse arches, we have the anterior and posterior. In the question, only longitudinal is asked, so we'll concentrate only on the longitudinal. Now, any arch, okay, longitudinal, each of the longitudinal arch will have three things. One is two pillars, the anterior pillar and the posterior pillar. One summit, means that is the height of that arch, and the joints which were forming it, okay. So, so if you see the medial longitudinal arch, now this is the medial longitudinal arch here, we can see. Okay, so the medial longitudinal arch, if you see, it is formed by the calcaneum. There is the talus, the navicular bone, okay, the three cuneiforms, and the medial three tarsals here you can see. Okay, so the medial longitudinal arch is formed by the calcaneum, talus, the navicular, the three cuneiforms, and the medial three tarsal bones. So these are the bones which are forming the medial longitudinal arch. Okay, so now the pillars here. So the pillars here, okay, so the medial half of the calcaneum. So here if you see, this is the calcaneum. So this forms the posterior pillar of the arch and the head of the three metatarsals. Okay, this is the metatarsal bone. So the head of those three metatarsal bones, okay, they will be forming the head of the metatarsals will be forming what? The anterior pillar of the arch. Okay, the summit means the highest point. Which is the summit here? If you see the talus. Okay, so the talus is the summit of this arch. So that is why the talus is also known as the keystone of the arch. So the joints here mainly are the talocalcaneo-navicular joint. This joint is the important joint which is helping to maintain that arch. Okay. And other one will be the subtalar joint. Subtalar joint is below the talus here, the subtalar joint, and talocalcaneo-navicular joint. So this will help. Next is the lateral. So that is about the bones, pillars, and the summit, the pillars, the summit, and the bones which are forming, or the joints which are forming. The lateral longitudinal arch. So lateral longitudinal arch is formed by the calcaneum here, portion of the calcaneum as well, and the cuboid and the two metatarsals. Okay, so this is when compared to the medial arch, this is slightly lower. Okay, lower, and almost it will touch. There is only slight gap between the ground level and the arch. Okay, so this pillars here. So pillars here, the posterior pillar here is formed by the lateral tubercle of the calcaneum, and the anterior pillar is formed by the heads of the fourth and fifth metatarsals. So the summit here will be which one? The summit will be the this one, that is the cuboid, at the level of the cuboid. Okay, so articular facets of these two here will be the summit near the calcaneum and the cuboid. And the joint mainly will be the calcaneo-navicular joint. Okay, so the summit will be this highest point near the subtalar. So this is the subtalar, because above will be the talus. So this subtalar portion will be the summit. Superior surface of the calcaneum will be the summit of it. Okay. Okay, so next is the factors. So before we understand, so I put this picture of a bridge. Okay, so now if you see this arch bridge, right? Now there is something here. If you can see, a wedge-shaped stone will be there. Usually in a bridge, or if you see some arched stone buildings, you can see that the center stone mainly will be here like a wedge-shaped. And that is known as the keystone, because it will be holding the rest of the stones there. Okay, so here also in the bridge. And these things which will be holding each other. Okay, this will be, we call them as the intersegmental ties. Okay, intersegmental ties. So usually intersegmental ties in the arch. Now keystone is the highest bone which is holding that entire arch. So we saw in the medial it was the talus, and in the lateral longitudinal arch it was which one? The superior surface of the calcaneum. Okay, that is the subtalar portion. Okay. Here the intersegmental, which will be holding the stones together or the bones together will be the ligaments. Okay, so ligaments forms the intersegmental ties. Then here, this one, that is the anterior pillar and the posterior. The two pillars will be held in position by what we call it as the tie beams. Okay, so this is called tie beam. So tie beam will be especially between the two pillars. So usually that is mainly formed by some of the muscles and the aponeurosis. Okay, and then we have the slings. Slings will be holding up, okay, the arch. So that is the sling. So here you can see this is the sling which is holding the arch up, maintaining the shape. Okay. So with this analogy, we will now see this one. Okay. Now this is which one? The medial longitudinal arch. Okay. So medial longitudinal arch. So medial longitudinal arch, when we see here, okay, so this is the medial longitudinal arch. So you know which is the, okay. So medial longitudinal arch here, when we see, this is the posterior. Okay. This is the posterior pillar and this is the anterior pillar. So anterior pillar was formed by which one? The three heads of the three metatarsals, whereas the posterior pillar was formed by the calcaneum. Okay. I don't know, something is happening. Sorry for this. Okay. Right. So now we will see. Is there any problem here? I'm trying to show that it's changing.
No, ma'am.
The screen is going on changing. I don't know why.
No, ma'am. No, from our end, it's no issue, ma'am.
Is it? See, it's happening like this. Okay. Yeah, I think it's all right. No, same thing is happening. I don't know why. Okay. Shall I continue?
Yes, ma'am.
Okay. See, the moment the recording is started again, the same problem started.
Just a minute.
Yeah, why is this happening? I have not zoomed here. All those things are off, but
One issue. Okay, ma'am.
yeah, I think, yeah. Yeah, I think so.
So start, ma'am.
Yeah, we'll see. Okay, so now here we will go one by one. So see again,
అది స్క్రీన్ పీపీటీది ఓపెన్ అయిపోతుందంట ఒకసారి చూడండి పీపీటీ
this percentage and all is changing. I don't know why. Something is pressed or something. Okay, I think it's all right.
So start now.
Yeah. Okay, so yeah. So the medial longitudinal arch, when we see now, so the things what we have to see is what are the factors? There is a keystone, there are intersegmental ties, then there is the tie beam and the sling. So we have to see now here in this medial longitudinal arch, which acts as the keystone. So the keystone here is basically the head of the talus. Okay, so this is the keystone. So the ligaments or the tie beams, okay, no, sorry, yeah, the intersegmental ties. So when we say intersegmental ties, it is these. So intersegmental ties, this is the tie beam and this is the sling. So the intersegmental ties which will help here are, that is the ligaments. So which are those ligaments? One is the plantar calcaneonavicular ligament. Okay, so plantar from the calcaneum to the navicular bone, we will have a calcaneonavicular ligament. Okay, which is otherwise called as the spring ligament. I think we saw it here. Okay, this is the calcaneonavicular ligament, otherwise called as spring ligament. Okay, and then we have the interosseous ligament. Interosseous ligament connects the adjacent bones. And the interosseous talocalcaneal ligament. Okay, talocalcaneal ligament. So these basically, so whatever those ligaments present between the bones and present between the main bones here, that is the talus and the calcaneum, and between the calcaneum and the navicular, they act like the tie beams, holding all the bones together. Okay, so not tie beams, sorry, intersegmental ties. So what acts like tie beams? Okay, so tie beams basically will be the aponeurosis. Okay, and the slings here. So slings will be this one. Okay, so sling, if you see here, this is one is the tendon of the tibialis anterior and the tendon of flexor hallucis longus. Okay, so these will act like the tie beams. Sorry, the slings which will hold the arch up, like maintain the arch, that is the concavity of the arch is maintained. So, and other one which acts like tie beam will be the, which one? The aponeurosis. Okay. So the medial part of the plantar aponeurosis as well as the abductor hallucis. Okay. Abductor hallucis assist along with the flexor hallucis brevis will act like the tie beam. Tie beams to maintain the arch. Plantar aponeurosis, the medial part of the plantar aponeurosis, the flexor abductor hallucis longus and flexor hallucis brevis, because flexor hallucis longus is acting like a sling. Understood? So here the keystone is the talus, okay, head of the talus. Then we have the intersegmental ties. Intersegmental ties are basically the spring ligament, the interosseous ligament between the bones, the metatarsals and other cuneiforms and all, the interosseous ligament, and another one is the talocalcaneal ligament. Okay, so they will help to act as the intersegmental ties. Then we have the, which one? Slings. Slings are tibialis anterior tendon as well as the tendon of flexor hallucis longus. And the tie beams will be the maintaining the two pillars, that is the plantar aponeurosis, abductor hallucis as well as the abductor, the flexor hallucis brevis. Then we, okay. So that was medial longitudinal. Now next is lateral longitudinal. So lateral longitudinal arch. Now the bones here, the keystone here was the highest summit was this one. Keystone will be the cuboid. Okay. The summit of it was formed by the superior surface of the calcaneum, no, where the subtalar joint will be there. So this portion, the keystone here will be the cuboid. Okay. So cuboid is the keystone of the lateral longitudinal arch. Then what do we have? The intersegmental ties. Okay, so intersegmental ties are short plantar ligament here between the calcaneum and the cuboid, and long plantar ligament. Okay, so it is between the calcaneum, cuboid as well as to the metatarsals. So the related, so that is the long plantar ligament. So these two, that is the short plantar and the long plantar. So they act like intersegmental ties. Then we have slings. So which are the slings here? If you see the slings here, they are the tendon of peroneus longus and tendon of peroneus brevis. Okay, peroneus longus and brevis, they act like slings. Whereas the tie beams here will be the lateral part of the plantar aponeurosis. Okay, then abductor digiti minimi brevis. Okay, abductor digiti minimi brevis and flexor digitorum brevis as well as the flexor digiti minimi brevis. Okay, flexor digitorum brevis, flexor digiti minimi brevis, and abductor digiti minimi brevis. So they act like the inner tie beams. So that is the factors maintaining. Okay. So the comparison between medial and lateral longitudinal arch, this has got more bones and more joints, less bones and less joints. The characteristic feature is resilience, means once, like, it basically the arch, as we walk on uneven surfaces, basically the arches were formed on evolution mainly to walk on uneven surfaces. Okay. So there is resilience, means it can again come back, like, it bounces back. Here it is rigid. It doesn't blend with the irregular surfaces. Okay. This is higher and more mobile. This is lower and less mobile. This is involved in propulsion during locomotion. That is especially when we initiate the next step in walking. So this is basically supportive. Okay, receiving the body weight. Summit is formed by the talus, here by the calcaneum, that is the superior subtalar surface. Then main joint is talocalcaneonavicular joint. Here the main joint is calcaneocuboid joint. Okay, so that is the thing. So only when the arches, okay, so when the arches are not maintained, it results in what we call it as the flat foot. So here basically the arch is absent. This is called as pes planus. Okay, so it is the commonest form of commonest condition in the foot. So here what happens, there is collapse of the medial longitudinal arch. So usually this happens during, so it can be congenital or sometimes it can be because of long hours of standing. Okay, the plantar aponeurosis and the spring ligament becomes overstretched. Okay, so because of that, what happens, the support of the head of the talus is lost and it is pushed downwards between the calcaneus and the navicular bones. So that results in flat foot. So that you need to write for clinical correlation for the arches. Then locking, short essay question, locking and unlocking movements of knee joint. Okay, so this is also a very important question. Even when you explain about knee joint also, as a long essay, you need to write about locking and unlocking as to what muscles bring about the locking and unlocking of the knee joint. So what do we mean by locking of the knee? Okay, so now when we keep the foot on the ground, okay, so when the foot is on the ground, the locking is defined as the medial rotation of the femur. So the femur rotates medially. Okay, how does it rotate? If the tibia is like this, the femur will rotate, okay, on the tibia during the terminal phase. So when you are standing straight, your foot is, the lower limb is in complete extension at the knee joint. Okay, so straight it is, right? So the terminal phase, to maintain that, the femur rotates like this. That is locking. Okay. So when the knee is locked, it becomes very rigid and all the ligaments of the joint become taut. Okay, they are tight. This is known as the screw home mechanism. Unlocking is when the foot is again on the ground. The unlocking is defined as the lateral rotation of the femur on the tibia during initial phase of flexion. Okay, so at the terminal stage of extension, it is, so we are almost, when we are taking the foot off the ground, what happens? There is flexion, isn't it? So that time the femur rotates laterally. So the unlocking is brought about by the popliteus muscle. So when the knee is unlocked, what happens? It further flexes, okay, by the hamstring. Further, it is flexed by the hamstring muscles. Hamstring brings about the flexion of the knee joint further. So the locking is essential. Why locking and unlocking are important is, locking is important to maintain the body weight, okay, during erect posture, and the lock joint must be unlocked to facilitate further. Okay, so once it is locked, it is helping you to maintain the erect posture and maintain the body weight. But now when you need to walk, unlocking should happen. Okay, so unlocking is brought mainly by the popliteus. Locking, okay, so locking will be brought by the quadriceps femoris muscle. Okay, so medial rotation of the femur on the tibia. So this is at the terminal phase of extension is locking. Lateral rotation of the femur on the tibia during the initial part of flexion is unlocking. This is brought about quadriceps femoris. This is brought by popliteus. So lock knee becomes rigid here. Unlock knee is flexed. Their ligaments become taut. Your ligaments are relaxed. Next short essay, deltoid ligament of ankle joint. Okay, so it's also commonly asked previously. So here the deltoid ligament is a very strong triangular ligament. Okay, so it is located on the medial side of the ankle. Deltoid ligament will be located on the medial side. So it has got two parts, the superficial part and the deep part. Okay, superficial part and the deep part. So above, both the parts have a common attachment to the apex and the medial margins of the, here you can see, of the medial malleolus. Below, the attachments of superficial and deep part will differ. Okay. So fibers are divided into three parts, that is the anterior, middle and posterior. So if you see here, this is the anterior fibers and posterior fibers. Okay. So anterior fibers are called as the tibio-navicular and are attached to the tuberosity of the navicular bone and the medial margin of spring ligament. Okay. So here if you see, this is the anterior fibers, otherwise called as tibio-navicular. So it is attached to the navicular as well as to the spring ligament. Okay. Middle fibers are known as tibiocalcaneal and they are attached to the whole length of sustentaculum tali. So this is the sustentaculum tali. So to that it is attached. And the posterior fibers, they are posterior tibiotalar fibers attached to the medial tubercle and adjoining part of the medial surface of the talus. Okay. From the tibia to the talus. So the deep part, that is the anterior tibiotalar, is attached to the anterior part of the medial surface of the talus. So that is about the deltoid ligament. Basically, it is a main ligament which helps to maintain the ankle joint. Next, semilunar ligament or medial meniscus. Okay. So here you will explain the answer under where it is, what is its feature and functions. So this medial meniscus, when we see, this is crescent-shaped intra-articular disc. It is made up of fibrocartilage. And when you see, it has a thick peripheral border and a thin inner border. So it deepens the articular surface of the condyles of tibia and partially divide the joint cavity into upper, okay, upper part, that is the meniscofemoral part, and lower part, we call it as the meniscotibial part, okay, tibial compartments. So like that, it will deepen the condyles, articular surface of the condyles, and divides that joint cavity into two compartments, above and below. Above is meniscofemoral, below is meniscotibial. Flexion and extension of the knee joint takes place in the upper compartment, whereas the rotation of the knee joint will take place in the lower compartment. Now, each of this meniscus, when we see, there is two, medial and lateral. So this meniscus will have two ends, anterior end and a posterior end. And they're attached to the tibia. It has two borders, the thicker outer border and a thinner inner border. And two surfaces. The upper surface is concave for the femur and the lower surface is flat for, in the peripheral 2/3 of the tibial condyles. So this is wider behind. So when you see here, it is wider behind than in the front. It presents anterior end and a posterior end, which are attached to the intercondylar areas of the tibia. And it is adherent to the deep part of the tibial collateral ligament. Okay, so this is the tibial. So for the deep part of the It is attached to the deep part of the tibial collateral ligament, and it is firmly attached to the tibial plateau by this coronary ligament. Okay, tibial plateau means that surface of the tibia. Short answer, capsule of the knee joint. So definition and attachment, you have to write. So it's a 3-mark question. So briefly you need to write. It's a thin fibrous sac. So it surrounds the knee joint, and it is deficient anteriorly where it is replaced by the patella. Okay, quadriceps femoris, medial and lateral plantar patella retinaculum, and ligamentum patellae. So anteriorly it is deficient. It is lined on the inner surface by the synovial membrane. So to the femur, it is attached above 1.5 to 1 centimeter beyond the articular margins. Okay, and it has got the 3 special features. That is, anteriorly it is deficient, where it is pierced by the suprapatellar bursa. Posteriorly, it is attached to the intercondylar line. Okay, and laterally it encloses the origin of popliteus. Okay, so those 3 things you have to write. So anteriorly it is deficient. Posteriorly, there is the intercondylar line. Okay, on the femur. So that along that line, there are 2 condyles, no, posteriorly, like round condyles. So that intercondylar line is there. So it will be attached to that. And laterally, it will enclose the origin of popliteus, because popliteus has the origin from the femur. Tibial attachment, it is attached about 0.5 to 1 centimeter beyond the articular margins. So here also it has 3 features. So anteriorly, it will descend along the margins of the condyles up to tibial tuberosity, where it is deficient for the attachment of ligamentum patella. Posteriorly, it will present a gap behind the lateral condyle for the passage of tendon of popliteus muscle. Okay, so you can see here. Okay, so here anteriorly, this is for the suprapatellar bursa on the femur part. Okay. You can see that is anterior. This is the anterior part of the tibia. So here also anteriorly down. Here it is deficient. Here the patella, that is ligamentum patella is attached here. So this is the capsules. This will be the intercondylar line. Okay. And here for the gap for the tendon of popliteus. So here it is slightly deficient. And it is attached here. Next question is cruciate ligaments. Cruciate ligament, you have to explain location, features, types, and function. Okay, so these are ligaments of knee joint. So they're all very important. So there are 2 thick, so these cruciate ligaments are 2 thick, strong bands, okay, which act as direct bonds of union between the femur and the tibia. So these cruciate ligaments, they are present inside the knee joint, okay. So they represent the collateral ligaments of the primitive. So basically they are the like remnants of the primitive femorotibial joints. So they maintain anterior-posterior stability of the knee joint, and they are called anterior and posterior according to their site of attachment to the tibia. So these cruciate ligaments, they are intracapsular. Okay, it means they are within the capsule, but extrasynovial, outside the synovial membrane. Okay, within the capsule, but outside the synovial membrane. The ligaments, they cross each other. Okay, so cruciate, that is why the name cruciate comes. They cross like an X. So the anterior cruciate ligament is attached below to the anterior part of the intercondylar area of the tibia. That is, intercondylar area, you will see it on the superior surface of the tibia. Okay, so there will be intercondylar eminence. So in that portion, it will be attached. So it will run upwards, backwards, and laterally, and it will be attached to the posterior part of the medial surface of the lateral condyle of femur. It is taut. It becomes tight during extension of the knee and prevents the posterior dislocation of the femur on the tibia and anterior dislocation of tibia on the femur. Okay. The posterior cruciate ligament here is attached below to the posterior part of the intercondylar area of the tibia, and it will run upwards, forwards, and medially, and is attached to the anterior part of the lateral surface of the medial condyle of femur. Okay. So just opposite of the anterior. It is taut during flexion of the knee, and it prevents the anterior dislocation of femur on tibia and posterior dislocation of tibia on femur. So if you remember one, the other one will be the opposite. So two things, like when it is, if you understand, there is no confusion, but if there is a confusion, like in anterior and cruciate, the way the direction is and how they prevent the dislocation, remember one of it, the other will be the opposite of it, okay? Next is spring ligament attachments is asked. So spring ligament is otherwise called as plantar calcaneonavicular ligament. It is a powerful fibrocartilaginous band, okay? So we saw it. What was it doing? What function was it doing in the arches? What was it acting like? Spring ligament. It was acting like the intersegmental ties, isn't it? So it extends from the anterior margin of the sustentaculum tali to the plantar surface of the navicular bone, okay, between its tuberosity and articular margin. So if you just know from sustentacular tali to the plantar surface of navicular bone is enough. It takes part in the forming the socket for the head of the talus, and it maintains the medial longitudinal arch. Its upper surface has a triangular fibrocartilaginous facet for the head of the talus, and its plantar surface here, it is supported by the tendon of tibialis posterior medially and by the tendon of flexor hallucis longus and flexor digitorum longus laterally. Okay, so these three tendons, that is tibialis posterior medially and flexor hallucis longus and flexor digitorum longus laterally, they will help in supporting this ligament. Bursae around the knee joint. Okay, so the location and the clinical. So the bursa, they are about 12 bursa around the knee joint. Okay, so 4 are anterior, 3 are lateral, 3 are medial, and 2 posterior. So the anterior bursae. So actually it is more of a than a short answer. It is a short essay question, the bursa around the knee joint. So if it is just 3 marks, you just mention how many are there. Like you have 4 anterior, 3 lateral, 3 medial, and 2 posterior, and just name them. You don't have to explain them, okay? But if it is a 5-mark question, then you need to write a little bit where it is present. So anterior bursae, we have 4. The subcutaneous prepatellar bursa, okay? Subcutaneous prepatellar. So this is the prepatellar bursa. So it lies deep to the skin in front of the lower half of the patella and upper half of the ligament. This is the ligamentum patellae and tibial tuberosity. Then subcutaneous infrapatellar bursa. This is the subcutaneous infrapatellar bursa between the skin and the smooth lower part of the tibial tuberosity. Then deep infrapatellar bursa between ligamentum patellae and the tibial tuberosity. Then suprapatellar bursa between the anterior surface of the lower part of the femur and deep part of the quadriceps femoris. So these 4 bursa, subcutaneous prepatellar, infrapatellar, subcutaneous prepatellar and subcutaneous infrapatellar, then deep infrapatellar and suprapatellar. Then the lateral bursa. The lateral bursa is the bursa between the fibular collateral ligament. Okay, this is the fibular collateral ligament between the fibular collateral ligament and the tendon of the biceps. And bursa between the fibular collateral ligament and the tendon of popliteus. Okay, so here between these two, tibial collateral ligament and fibular collateral ligament and the tendon of biceps. Fibular collateral ligament and the tendon of popliteus, and the bursa between the tendon of popliteus and the lateral condyle of femur. Okay, so this one. So this bursa is a synovial tube around the tendon of popliteus, hence it communicates with the joint. Then the medial bursa this side, the bursa which separates the tendon of this sartorius gracilis semitendinous, this gyrope muscles, no, from each other and from the tibial collateral ligament. This is known as bursa anserina, and the bursa between the tendon of semimembranosus and medial collateral ligament. So these are the medial bursae. Posterior bursa 2, that is between the lateral head of gastrocnemius and the capsule of the joint, and medial head of gastrocnemius and the capsule of the joint, which is otherwise called as Brodie's bursa. So clinical correlation, here also, if it is 3 marks, just name the conditions. If it is a 5 marker, you explain. Okay, so here I've explained both so that you know what to write for 5 marks. Okay, if it is 3 marks, just name the condition. So housemates knee, inflammation of the prepatella bursa. So there is a friction of the bursa against the patella when it comes in contact with the ground, especially housemates, no? Like if you see those English housemates, they used to lie down and scrub the floor earlier. Okay, they used to do here also, but nowadays they don't, right? We have all the mop sticks. Clergyman's knee. So clergyman's knee is the inflammation of subcutaneous infrapatellar bursa. So it occurs because of continuous kneeling down. Okay, during prayer, clergymen, roofers, floor tilers, all those occupational people also it can happen. Then Baker's cyst is the chronic inflammation of the bursa deep to the semimembranous, and it presents as a cystic swelling. Okay, cystic swelling in the medial part of the popliteal fossa. This is known as Baker's cyst. So with this, we complete today's revision class. So thank you for watching Auricle. So if you haven't yet downloaded the app, kindly do it on Google Play and App Store and start your journey towards your successful future with Auricle. So for more content, you can follow our social media handles on Instagram, Facebook, Telegram, and YouTube. Okay, until then, next time.